Hello, guys. Welcome back. We've talked about diabetes. Now we're continuing on through Unit 2. The rest of Unit 2 is more focused on respiratory system. So that's where we're going to be hanging out for a while. So, Chapter 17 is assessment of respiratory function. So, there's some basic anatomy and patho covered here, and then diagnostic tests and how we assess a patient's respiratory function. So, let's get started. So, A&P refresher, you have your upper respiratory tract and lower respiratory tract. And they call it tract, TRACT, just because it's like a kind of always think of tract as a word like a train track, like there's one place that this goes kind of thing. So upper airway is your nasal cavity, so nostril into the nasal cavity. And then you would technically have just the pharynx and larynx would be a kind of upper airway. Lower airway would be starting with the trachea, the tube that runs through the length of your throat, basically on the anterior side, and then your lungs, and then the various microscopic ends of the bronchi. That's the tubes of like the upside down tree. Basically, you call those alveoli. The alveoli are where the gas exchange happens. So, goal of the function of our respiratory system, pretty straightforward: oxygen transport, respiration, ventilation. I would also kind of say oxygen and CO2, carbon dioxide transport. The movement, gas exchange is the epitome of why we breathe. And we definitely need oxygen, but it's just as important for our lungs to regulate our CO2 level. Respiration just means all that term means is just the movement of these molecules, basically, is all it's saying. And ventilation is the movement of the walls of the thoracic cage and the diaphragm. So ventilation would be the movement of the muscles around the rib cage to kind of pull and contract, and the diaphragm to move to cause uh, breathing, basically. So with ventilation, keep in mind that inspiration, which is breathing in, it's either called inspiration or inhalation. Breathing in is an active process, requires energy. So what happens is, right, our muscles around our thoracic cage contract, kind of pulling the chest out and upwards. That's shown here with that arrow. And at the same time, our diaphragm pushes down towards our GI area, towards our abdomen. So diaphragm pushes down, muscles around the rib cage and push the chest up and out. And that makes the lungs big for inhalation. That's active process. Now breathing out, expiration, uh, expiration is a passive process. It should be a passive process. Means the what drives this is basically atmospheric pressure on the outside of the lungs. So when the pressure reaches pretty high at the peak of inspiration, then that pressure shift causes the air to move out of our lungs, and as it happens, the muscles relax. So chest muscles retract, basically gotta go back to the resting state. Diaphragm pushes back up, going back to its resting state. So breathing out, expiration should be a somewhat passive, it should be a passive process, low energy requirement. So if someone's working hard to breathe out, that would be concerning finding. And then so these are pictures of the alveoli. So remember that from our right side of our heart comes circulation, that is pulmonary circulation. It's dedicated capillaries that surround all the alveoli sacs in the microscopic smallest portion of our lungs, and that's where the gas exchange happens. It's a gaseous diffusion. The principles basically on areas of high concentration, areas of low concentration. So, when we breathe in, large amounts of oxygen come in, and then the concentration is slightly higher compared to CO2. CO2 gets let go by the hemoglobin, and the hemoglobin will pick up the O2. So perfusion is basically a term that we talk about the amount of blood flow through the pulmonary vasculature. So the relationship really is based on the amount of air movement, and then ventilation, that would be ventilation, the amount of air movement, and perfusion, the amount of blood flow through the lungs so that gas exchange can happen. And that's what this is talking about. So you might have heard something called a VQ ratio, and that's basically VQ ratio is a ratio between ventilation, so movement of lungs, lung tissue, and perfusion, movement of the blood flow through the pulmonary capillaries. And this needs to be balanced, obviously. Um, so if this is balanced, that's adequate. Gas exchange happens. If it's not balanced, that could be something like airway is blocked for some reason, or lung compliant. So the elasticity of the lungs and the movement of the muscles is diminished. Even gravity and atmospheric pressure can alter VQ ratio technically. Like if I was to climb Mount Everest, that sort of thing. Chart 20./2 in the book has an example of this. But think of it this way, basically, you have a low VQ ratio that's basically saying flow is great, but ventilation's not. So blood is basically bypassing the alveoli without proper gas exchange happening. So examples of low VQ states with their improper ventilation is pneumonia, because all the mucus production. Atelectasis is a intense amount of mucus production. So mucus plug that actually plugs up a bronchiole and shuts off whole portions of alveoli, tumors, that sort of thing. A high VQ ratio basically is saying that ventilation exceeds perfusion. A low VQ is saying perfusion exceeds ventilation. So in a high VQ, ventilation exceeds perfusion. There's not enough blood supply for gas exchange. So like cardiogenic shock, like hemorrhagic shock, loss of huge amounts of blood. Pneumothorax technically falls into this just because of its crushing the lungs. It would be kind of a both V and Q mess up. But for high VQ, think lacking perfusion, low VQ saying lacking ventilation, lacking movement of the lungs, basically. Excuse me. So there is a difference technically between hypoxemia and hypoxia. Okay. And you need to know the difference. So this is a need to know. I'm highlighting this as a need to know. It gets confusing, but this is need to know. Hypoxemia says there's not enough oxygen in the blood, and this could be for several reasons. This could be related to probably ventilation or VQ ratios. Hypoxia, without the emia, says that there's not enough O2 getting to the tissues. Now, why? That could be blockage, diminished blood flow, so diminished perfusion. It kind of depends. Hypoxemia is more of a tangible thing we can see. Hypoxia, hypoxemia, we can see on an ABG, we can check blood for that. Hypoxia is more symptomatic based, manifestation based. That's kind of the main difference. So if someone's hypoxia, they'd have blue tinged lips, they'd have cyanosis, we'd call them hypoxic, but we don't know without verification, right, of their blood if they have hypoxemia necessarily. They're just lacking tissue flow for some reason. That's kind of the difference. So patients experiencing hypoxia, which of the following physiological process is most directly responsible for oxygen delivery to the tissues? So see what you think. See what you can kind of work out here. You said perfusion, you're correct. So with hypoxia, it's a problem of perfusion usually. Like blood flow is not getting where it's supposed to be. Their ventilation is probably okay. Hypoxemia, low in the blood, means there's likely more of a problem with ventilation. So if you want to kind of help think of that difference between hypoxemia and hypoxia that way, that's probably not the worst way to think about it. Yeah, so you could think of it this way. You could think of it as, if I'm talking about a problem with ventilation, it means that my blood levels of oxygen are going to be low. So ventilation, problem with the lung compliance, the effectiveness of the lung expansion, any of that mucus production, all that stuff. Probably more like I'm going to see, I'm going to see low levels of oxygen in the blood. So hypoxemia. If there's a problem with not enough blood flow, hemorrhage, bleeding, blockage to blood somewhere, perfusion issues, you think of the signs and symptoms that manifest itself in a systemic way, hypoxia of tissues not getting enough blood, basically. Hopefully that helps confuse it up. But the difference between hypoxemia and hypoxia is going to be need to know. So kind of mark that, make a note about that. So respiratory assessment. What do we want to know? So some things, right? There's always history, but things like, are they having symptoms? Dyspnea, which is just difficulty. I always remember dyspnea is just the D for dyspnea, means difficulty breathing, and that's a described manifestation by a patient. You can recognize this as well, but it's also something that's usually described by them. Tachypnea or bradypnea, so fast rates of breathing, low rates of breathing. Do they have a cough? Is it productive? Is it producing sputum? Sputum is basically the technical word for the phlegm that we cough up. Is it yellow, green? Is it clear? Does it have blood in it? That's hemoptysis. Is it a cough only happening at night? Is a cough only happening with activity? Patient's appearance, right? Do they have clubbing of their fingernails, which shows us chronic years of low oxygen levels? Cyanosis, nose and sinus mucus drainage, trachea deviation. That's a scary one. That would be an indication of lung collapse. Chest circumference and configuration. Is their chest bulging out further than it should? Does it seem smaller? Their breathing pattern, and rate, back to the tachypnea, bradypnea, but also with breathing pattern, the quote, like use of accessory muscles. If you hear anybody saying use of accessory muscles, it's a visual objective symptom, objective sign that we can see someone is like using their muscles hardcore to inhale and then still using accessory muscles usually to exhale, which should be a passive process. If their chest is rising in kind of a very sharp, drastic way, and they're using more muscles than like abdominal muscles, for adults, you shouldn't see an adult using their abdominal muscles to breathe. It just shouldn't happen. Now, in infants, that's a whole nother discussion. But in adults, you shouldn't see them using their stomach muscles and shoulders to breathe. If they're using shoulders and stomach muscles to breathe, that would be called use of accessory muscles, and that would be a very big deal to think about. So here's some of the other assessment characteristics. So barrel chest, we'll talk about that more when we talk about chronic or the COPDs, the chronic, but that's emphysema. The chest wall size changes. That would be something. The clubbing of fingernails, again, is like normal nail bed. Fingernails kind of make this clubbed appearance at the end, versus the normal kind of smooth finger here. That's basically chronic low levels of oxygen. This cyanosis, right? You can see blue tinged nail beds. Those are all, again, kind of objective signs that we can physically see. Another big diagnostic part of our breathing is listening to the lungs. This is important for us as nurses. We can recognize changes in patients and their breathing status earlier by recognizing lung sounds. So if you talked about normal lung sounds, they sound vesicular. The technical name for that is normal is vesicular. I'll write that up here. And that's what the book notes. I mean, it should just sound on a stethoscope like a very kind of mid-pitch whooshing sound, basically, lack of a better term. Just you can tell air is moving, but there seems to be no harsh high pitched or really low pitch sounds, no extra sounds, very just whoo, like just a nice smooth sound, basically. And so some of the other ones, Diminished is kind of what it means. Usually someone will be diminished in the basis, which means that it's the sound of that low kind of pitch whooshing that would be considered vascular and normal is like very faint and hard to hear. That's diminished, and that could happen with pneumonia, atelectasis. Wheezes, your common condition is asthma, but you hear this with chronic bronchitis or even acute bronchitis. But this is the airway, specifically the bronchioles, are constricted for some reason. So this causes like a high pitched, sometimes people call it a high pitched musical tone, is sometimes the definition used, but it's a high pitched tone. And then crackles. Sometimes some books and some places will note crackles as another name as well, called rails. So if you hear the term rails and crackles, these are synonyms. They mean the same thing. But rails can be either coarse or fine. So coarse being much more louder and rugged, and fine being a little bit more high pitched and more petite, I guess would be the right way to say that. But the crackles sound like snap, crackle, pop. Like if you remember Rice Krispies, not the Rice Krispie treats, but Rice Krispies, the actual cereal. If you were to pour that in a bowl, because of its aeration, as it sat in the milk, it would make this slow kind of popping sound. Kind of like Pop Rocks, but I don't know if that's the best example. There may not be too many 90s kids that know what Pop Rocks are here, but so that kind of sound. And then stridor is heard usually only over the trachea, and it's a very, very high pitched like whine sound, and it is an indication of an emergency situation because it's an upper airway obstruction, which means something is blocking air movement through the trachea typically. So stridor is an emergency situation, but you're commonly only going to see this with children based on acute tracheal swelling or like physical foreign body lodgement, that kind of thing. And then rhonchi is a low pitch sounds, usually related to partial airway obstruction and mucus development. So really low pitch. And I've got a video that does a good job of showing us all these sounds. These are going to be need to know assessment data. So you want to try to get these sounds straight for sure. Another chart that's helpful kind of talks about where you would hear these things and kind of describes them. So again, rails is your crackles, coarse or fine. This is usually indicating like fluid. So it's usually in the smaller airways around close to the bronchioles, right around the alveoli. And this is saying fluid in the lungs, like in the alveoli and the bronchioles. And this is congestive heart failure, pneumonia. Rhonchi are usually the larger airways, the larger bronchi. This is like fluid obstruction, swelling. So some of the COPDs could be in pneumonia as well. Wheezing is a huge amount of constriction in the bronchi. So you get that musical high-pitched sound from air passing through swollen bronchi. And you see this with asthma predominantly, but you can also see this with acute or chronic bronchitis. And then again, stridor, you're only going to hear over the trachea, upper airway. There's either a foreign body or huge amounts of swelling, injury to the trachea, something like that. And that's an emergency if I hear stridor. So let's watch this video. Nurse Sarah gives us a great rundown of the of all of our good breath sounds. So let's take a look at this. I think this is a great resource if you're just not familiar with breath sounds.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to talk about the different types of adventitious lung sounds. So let's get started. Adventitious lung sounds are abnormal sounds that you hear during auscultation that shouldn't be there. And I want to cover 5 main types that you want to be familiar with. The first type is known as crackles. These are also sometimes called rails, and you can further divide them into fine crackles and coarse crackles. There's also wheezes, rhonchi, stridor, and pleural friction rub. Now, whenever you're auscultating lung sounds and you're trying to identify that particular abnormal sound that you're hearing, you want to make sure that you ask yourself the following questions. The first question deals with timing. Ask yourself, are you hearing this mainly on inspiration or expiration, or even both? Then try to determine the pitch of the sound. Is it high pitch or low pitched? Followed by if this sound is considered discontinuous or continuous. This refers to the length and the nature of that sound or sounds produced. For example, if the abnormal sounds are distinguishable individually and occur in succession, such as the individual pops and fine crackles, and those sounds generally last less than 250 milliseconds, the sound is considered discontinuous. However, if the sound is more constant in nature, generally lasting longer than around 250 milliseconds, it is considered continuous. And then another question you want to ask yourself is about location of that sound. Where are those sounds mainly heard? Are they mainly heard in the large airways, like the trachea, the large bronchi, or those smaller airways, which involves the alveoli and the bronchioles? And then lastly, try to determine if this sound has a defining characteristic to it that's just really hard to ignore. For example, the sound sounds like a harsh grating noise, or squeaky musical whistling, or snoring, or squawking, which could hopefully help you determine what kind of sound you're hearing. So first, let's go over crackles. Fine crackles are sometimes referred to as rels. And the first thing what I want to do is I want you to listen to an example of what fine crackles may sound like. Now, how do you know that you're hearing fine crackles? Well, you want to pay attention to the timing. With fine crackles, you're going to hear those towards the end of inspiration, and they're going to be really brief. You also want to pay attention to that pitch. Fine crackles are going to be high pitched. You also want to make sure that they are discontinuous, meaning that you're able to distinguish those individual popping, cracking sounds that are occurring in a series, so they're intermittent. And these sounds tend to be located in small airways. Plus, they're going to have this defining characteristic. They're going to sound very similar to popping or light crackling of a fire, and they cannot be cleared with coughing. And again, let's listen to that sample of fine crackles. Now, what's causing this sound? Well, whenever the patient breathes air into those small airways, like the bronchioles or the alveoli, which are deflated or collapsed, it causes them to all of a sudden crackle or explode open, which allows you to hear that high-pitched crackling noise. And fine crackles can occur in cases of congestive heart failure, atelectasis, pneumonia, and pulmonary fibrosis. Next up is coarse crackles. Let's listen to some audio of what coarse crackles may sound like. Now, how do you know that you're hearing coarse crackles? Well, you want to pay attention to their timing. Coarse crackles tend to occur around the beginning of inspiration, but they can extend into expiration, and they tend to be longer than fine crackles. Also, their pitch is low and they are discontinuous. In addition, they tend to be located in the large airways, such as the bronchi, and they have specific defining characteristics. These coarse crackles tend to sound like a gurgling or bubbling sound that is not cleared with coughing. And again, let's listen to this audio of coarse crackles. Now, what causes this sound? Well, it tends to occur whenever patients breathe air into partially blocked airways, like those large airways such as the bronchi, that are filled with fluid or really thick mucus. So whenever you're trying to think of lung conditions that will cause this sound, think of lung conditions that present with fluid or thick mucus. And these conditions could include heart failure due to pulmonary edema, which is fluid in the lungs, or severe cases of pneumonia, or bronchiectasis, which is a chronic lung condition where the bronchi are enlarged due to chronic lung disease, for example, like cystic fibrosis, or infections that result in mucus secretions. Now let's talk about wheeze sounds. First, let's listen to some sample audio of what wheezes may sound like. Now, how do you know that you're hearing wheezes? Well, you want to pay attention to the timing. With wheezes, you're mainly going to hear them on expiration where they're going to be the loudest, but you can note them on inspiration and expiration. And their pitch is going to be high. In addition, they're going to be continuous and located throughout the respiratory system. And they will have a defining characteristic when you listen to them. They will have this squeaky musical whistling noise to them, and you may even be able to hear them without a stethoscope, especially if your patient's having an active asthma attack. Now, it's important whenever you hear these sounds that they're not mainly coming from the throat area, because this may indicate stridor. And again, let's listen to that audio of what wheezes could sound like. So why is this sound occurring? Well, it occurs because the airways have started to narrow, meaning they have started to get smaller. So as air is squeezed through those airways, it creates this squeaky musical whistling sound. And it can occur in cases of asthma, COPD, or any type of lung infection that narrows those airways, like with a viral respiratory infection. Next is rhonchi. So let's listen to some audio of what rhonchi may sound like. Now, how can you know that you're hearing rhonchi? Well, you want to pay attention to the timing. Rhonchi are mainly heard on expiration, but you can hear them along with inspiration. And they're going to have a low pitch and be loud. In addition, they're going to be continuous and located in large airways like the trachea and the bronchus. And they're going to have a defining characteristics where when you listen to that sound, it's going to sound like a snoring or a snorting sound that can decrease or go away with suctioning or coughing. Now, it's important to note that some literature will actually classify rhonchi as a type of coarse crackle or a type of wheeze. So whenever you're trying to identify these lung sounds, always go by your facility or your professor's recommendations for how they want you to categorize rhonchi. So again, let's listen to that audio of rhonchi. Now, what causes this sound? Well, it occurs whenever air leaves the trachea and bronchus and it hits secretions like mucus and fluid. And whenever it does this, it creates this snoring-like sound that you're hearing. And this can happen in cases of bronchitis, pneumonia, and COPD. Next is stridor. So let's listen to some audio of what stridor may sound like. Now, how do you know that you're hearing stridor? Well, you want to pay attention to a few things. First thing is timing. Stridor can be heard on inspiration or expiration, and it's going to have a high pitch. In addition, it's going to be continuous and located mainly in the upper respiratory system, like the trachea/throat area. And it's going to have a defining auditory characteristic that you really can't ignore. It's going to sound like this screeching, squawking noise that's coming mainly from that throat area. So again, let's listen to this audio of stridor. So what causes this sound? Well, it's occurring because there's narrowing of the larynx and the trachea from swelling due to some type of infection or blockage from an object. And it can actually progress where that airway will be completely blocked off. Therefore, some cases of stridor are life-threatening and require immediate attention. So it depends on the severity of the stridor, how severe does it sound, and what is actually causing it. Now, stridor can be caused by cases of epiglottitis or croup, where you may hear it referred to as a barking cough in the pediatric population. It can also be caused in cases of anaphylaxis or if there is an object stuck in this throat region. Finally, we have pleural friction rub. So let's listen to some audio of what a pleural friction rub may sound like. Now, how do you know that you're hearing a pleural friction rub? Well, you want to pay attention to the timing. With pleural friction rubs, they can occur on inspiration and expiration, and they're going to have a low pitch to them. In addition, they can be discontinuous or continuous. It really depends on the severity of the rub and what's going on with your patient. And it's located in the pleural layer, which are the layers that surround your lungs, which is made up of the viscera pleura and the parietal pleura. In addition, it's going to have a defining characteristic that you're going to be able to note on auscultation. You're going to hear this harsh grating sound. In addition, your patient's probably going to have pain, especially when they take deep breaths in or they cough. Now let's listen to that audio of a pleural friction rub again. So what causes this sound? Well, it occurs whenever those pleural layers become inflamed and rub up against each other, because normally the visceral and the parietal pleura are separated by a small space. So as the patient breathes in, those layers will just glide over one another. But when those layers become inflamed, that space shrinks, which allows those layers now to rub up against each other, creating pain and that harsh grating noise that you're going to hear. And it can happen in cases of pleurisy, which just means inflammation of those pleural layers, pneumonia, pulmonary embolism, tuberculosis, and some forms of lung cancer. Okay, so that wraps up this video. And if you'd like to watch more videos in this respiratory series, you can access the link in the YouTube description below.
All right, continuing on here. So if you have a patient has a large collection of fluid in their pleural space during auscultation in the lung field, you'd expect to hear what if you had these options anyway? It probably would be click the head. Probably be the first one, wheezes or crackles, because of crackles, probably especially, or rails more related to fluid movement. Potential, you could have, potential there could be inflammation in the pleural space, and so you could hear the friction rub noise. But you probably make the argument for wheezes or crackles, more likely crackles or fluid sounding movement. So diagnostic methods around breathing. Oh, so let me ask a question too. The nurse auscultates patient's lungs and they hear a high pitched sounds during expiration. I'll say high pitched musical sounds during expiration. What's the most likely cause of this finding? All right. If you answered number 3, you're correct. Airway obstruction. So this is wheezing. So this is like chronic bronchitis, acute bronchitis, asthma. And basically airways become smaller, so they're obstructed. Pleural effusion would probably be that friction rub sound. Pulmonary edema could be crackles, probably coarse. Atelectasis would be possibly like the rhonchi. So lung diagnostic test for lungs, the main test that a lot of people will talk about is pulmonary function test, or shorthand PFTs. Pulmonary function tests basically use spirometry to determine lung volumes, and that tells us a lot about a person's overall lung function. This is an aid really in diagnosing, PFTs are a big aid in diagnosing chronic respiratory disorders. So some of the stuff that's on this chart: total lung capacity is the volume of air in the lungs upon the maximum effort of inspiration. Healthy adults averages around 6 liters, 5.5, 6 liters for total lung capacity. Forced vital capacity is an interesting one, but this is the amount of air that can be forcefully exhaled. Another big one to kind of highlight is probably tidal volume. This is a normal volume of air displaced between normal inhalation and exhalation with like no extra effort. So tidal volume would be relaxed, non-effort related breathing volume. And then reserve volume. Reserve volume, or it's known here in this chart too, Residual volume is the amount of air that remains in the lungs in the passageways after expiration. This is normal for gas exchange. So, residual volume, there's always a volume of air that stays in the lungs in between breathing in and out. Why? Well, gas exchange still needs to happen. And even in that split second between you breathing or that second in between you breathing, that's too much time to not have gas exchange happening. It's a whole chunk of time where CO2 doesn't get rid of and oxygen doesn't get gained. And so that would be a terrible thing for us. So we have a residual volume or basically to keep us alive, for lack of a better term. So spirometry is kind of this, right? Breathing into a machine, getting our volume, seeing what it is. ABGs are another diagnostic test. Again, that tells us CO2 levels and oxygen levels. This would be your tried and true method of kind of officially saying someone has hypoxemia. Also, we use pulse oximetry. The pulse oximeters are great for general. They give us a O2 saturation number based on a infrared light bouncing off the nail bed and checking red blood cells for oxygen levels. Sputum and tissue cultures, swabbing the upper airway, oral mucosa for infection, and then sputum cultures are the big thing. They cough up sputum. We can take it and see if it grows anything. If it does, you would call that pneumonia. If it doesn't grow anything, then we can assess the sputum for its color, consistency, quality. Again, if it's like pink, that's probably blood. That's not a good sign. So it just depends. Differences between all the O2s. So there's some O2s that get highlighted as part of diagnostic testing. SpO2 is the pulse oximeter one. So that's known as oxygen saturation. That should be for 95 to 100% for most patients. So SpO2 is pulse oximetry. That is the finger probe. That should be 95 to 100. SaO2 is the ABG. So SaO2 is ABG blood analysis of oxygen saturation, a little bit more accurate, should be 94 to 100%. And then the PaO2 is also part of the ABG. Usually they have both SaO2 and PaO2. PaO2 is the partial pressure of oxygen, and this reflects how well oxygen is able to move from the lungs to the blood, like the movement, more about more about the ventilation component. PaO2 is. This is only going to be found in ABG, and this would be 80 to 100 is the number you're looking for on a PaO2, 80 to 100. And then FiO2 is a concentration of oxygen a person inhales. So this is FiO2 is usually a setting on like someone that's intubated, right? And we're doing their breathing for them with a machine. We set the FiO2. FiO2 is just a concentration of oxygen in the air someone's breathing. Normally, on Earth anyway, we're about 21% oxygen is what we have in the air. Other diagnostic tests, definitely imaging. There's chest X-rays are kind of the tried and true. CT scans, MRIs are the most detailed of the imaging. Fluoroscopy, angiography, PET scan. So we can do some scans that involve injecting dye. Those are going to be more in place for perfusion assessments, perfusion around the lung capillaries, around the alveoli. That's what you're going to use some of those tests for. And then we can do physical like visual inspection of things, bronchoscopies, thoracoscopies. These are endoscopic procedures. So a bronchoscopy kind of tried and true to like physically look at the lung and see them visually for damage and inflammation. It's a direct inspection of larynx, trachea, all the way down to the bronchi. We can do visualization here. The doctor can make an assessment from that. Where they can also, usually in bronchoscopies, they'll collect specimen of the sputum there, and that's like your most sterile, accurate specimen. And also, if there's a tumor, it can be visually, and we can see it on imaging, but we can go into the lungs and visually see it. And thoracoscopy is basically a small incision that they do in the pleural cavity. We'll talk about thoracentesis in a second, but all of these procedures, they need to be MPO, especially because of we're messing with their gag reflex and the epiglottis, and we don't want them to vomit and end up in their lungs. That'd be aspiration. Excuse me. So bronchoscope, again, we're looking visual representation. Thoracentesis, this is that word thoracentesis just means to puncture the thorax is all it really means in like the root word. Um, we could be doing this to place a chest tube for decompression, but a lot of times it's if there's fluid or any exudate that builds up in the pleural space, that could cause a lung collapse. And so we want to diagnose them the best we can by knowing what that fluid is. And so a lot of times we'll drain the fluid just to make sure the lung stays inflated. So we'll drain the fluid and then we can test it. You know, if it's clear, that's a fluid shift that we need to deal with. But if it's exudate that's purulent, then we're worried about infection. That's bad. If it's blood, that's even worse because where's that blood coming from? Why is it there? There shouldn't be but a very thin amount of fluid in that pleural space. So thoracentesis is a procedure we can do like a needle aspiration. We can put a needle into the pleural space and actually drain it. And as a nurse, we just be helping with the bedside setup. The patient needs to sit up, that sort of thing. And then for a biopsy, they use a very thin needle to check abnormal tissue. And again, we could do a biopsy from a tumor through a bronchoscopy and visual cues that way. So a nurse is assessing a patient for shortness of breath. Which assessment finding requires immediate intervention? So let's just go on with assessments. What's in with this question? What do you think here? All right. If you answered the first one, number one, use of accessory muscles and nasal flaring. So the book highlights this. The accessory muscles, I mentioned this. This is like using your shoulders and your stomach to breathe. We shouldn't see that. It should be breathing should be a very passive thing that we don't even hardly visualize normally, like talking to someone. All these other things, that O2 sat is good. The respiratory rate slightly elevated, but nothing too concerning. There's mild wheezing, but that could be related to acute bronchitis and illness. And if there's no signs of respiratory stress, then this would trump it, right? Because this says dyspnea, this says difficulty breathing. The nasal flaring is where the nostrils flare out, and that's just our body's way of trying to move as much air as possible. That's all very concerning, much more concerning than mild wheezing at this time. So that was chapter 17, assessment, diagnosis, diagnostic tools associated with respiratory conditions. We'll move on to chapter 18, and then we got chapter 19 and 20. And 19 and 20 are doozies, especially 20. 20 is the lower respiratory diseases, and that's where a lot of this stuff comes from. So hang in there with me.